Okay, it looks like we're slowing down with entries, so we can go ahead and kick this off. Thank you so much for joining us today for our webinar, Building a Business Case for Collaborative Care and Conducting Caseload Reviews. For those of us that are joining a webinar for the first time that ACCC has posted, the Association of Cancer Care Centers is an organization that helps translate clinical findings into action through how-to, looking at quality and process improvement, effective measures and guidelines. We are a large organization that represents the entire continuum of those that work in oncology, working with private practices, hospitals, community centers, and academic medical centers, and representing everyone from clinicians to administrators, financial advocates to support staff. We would like to thank our sponsors and partnerships today. And this is done in partnership with the Association of Oncology Social Work and the American Psychosocial Oncology Society. We also are pleased to be able to offer one credit today for a new partner, the American College of Healthcare Executives, who will be offering one qualified education hour for this webinar. And with that, I'm excited to introduce our faculty and speakers today. We are joined today by Dr. Tom Lynch, who's the president and director at Fred Hutch Cancer Center, Shelley Anderson, who is the hospital president at Memorial Sloan Kettering, Dr. Jesse Fan, who is the medical director of psychosocial oncology at Fred Hutch Cancer Center, and Dr. William Pearl, who is the chair of the Department of Psychiatry and Behavioral Health at Memorial Sloan Kettering. So a pretty stellar lineup this afternoon to speak about collaborative care models. With that, I will also say that there are noted disclosures here. And I can turn this over to Dr. Pearl and Dr. Fan. Thank you.
So thank you, Teresa, and thank you everyone for joining us. And welcome to the American College of Healthcare Executives to this webinar. Because this might be the first webinar some of you are joining in this series on implementing collaborative care, I wanted to start with just a quick introduction to what collaborative care is before we get into the conversation with Shelley Anderson and Tom Lynch. Next slide. I posted this on LinkedIn about 3 months ago, and to me, this seems like a pretty good business model for collaborative care. And I think probably for many of the clinicians who are here, you would think this would be a good business model too. And I'll just read the first sentence. This post got thousands of impressions and lots of comments and people reaching out to me for more discussion about it. So it generated a lot of interest, but here's the first sentence. If there were an evidence-based model of supportive care that increases access, improves outcome, increases patient and provider satisfaction, eliminates disparities in care, and is financially sustainable, wouldn't you expect every cancer center to be using it? But despite what sounds like a good business model, very few people are actually doing this. Next slide. There was a really good commentary in the Journal of Clinical Oncology earlier this year by Dr. Sedom and colleagues about how non-drug innovations and breakthroughs in oncology, things like exercise and monitoring patient-reported outcomes and early palliative care, really don't break into clinical practice in oncology in the same way that drugs do. Like, for example, if a new drug is presented at ASCO, the next day, everyone is using it, it becomes standard of care. And the same thing doesn't happen for non-drug innovations and systems, even ones that have large impact. And the authors felt that some of this is related to systems implementation, but part of it is related to not having financial incentives or financial structures for some of these things. And this is where I think collaborative care is different than some of these other non-drug oncology breakthroughs and why we should be using it. Next slide. However, collaborative care has a real marketing problem, and it's kind of like the parable of the blind men touching different parts of the elephant and all describing their experience as being something different. If you look up collaborative care on PubMed, you'll see lots of randomized controlled trials for very specific psychiatric disorders. And so you may say, oh, collaborative care is an intervention for depression, or it's an intervention for anxiety. If you talk to psychiatrists like Jesse and me, we'll say it's not really a intervention for specific disorder. It's a system of care. There's been randomized clinical trials for most psychiatric disorders, and these principles extend beyond individual disorders, so it's a system of care. However, I think the historical perspective gives us the best perspective on it. That collaborative care was an idea way ahead of its time, way before what implementation science is today. And so I think there wasn't the language for what it was back when it was created. It really is an implementation strategy for evidence-based interventions. It was developed back in the 1990s in the golden age of psychiatry research, when lots of randomized clinical trials were coming out showing the efficacy of cognitive behavioral therapy for depression, for anxiety, the psychopharmacology trials for SSRIs treating depression and anxiety. And this was a strategy to get those evidence-based treatments from research into clinical practice in medical settings. And over the last 30 years of trials on collaborative care, these implementation strategies are now evidence-based. So it's evidence-based implementation strategies for evidence-based interventions. This is all very over-determined at this point. So if you set this up, it will work. Next slide. I'm going to describe collaborative care in 4 sentences. Collaborative care is a population health approach that uses team-based, measurement-based step care to deliver high-quality, evidence-based psychosocial care. Next slide. Collaborative care efficiently uses resources to deliver care to more patients while improving outcomes. So with the same resources, more patients, better outcomes. Next slide. Medicare CMS established billing codes for collaborative care to support and sustain implementation. So this is what makes collaborative care different than exercise, makes it different than monitoring patient-reported outcomes. There's actually financial incentives and a structure for implementing this into clinical care. Next slide. And lastly, collaborative care is adaptable and can include other supportive services such as palliative care. The Dana-Farber model of collaborative care integrates psychosocial oncology and palliative care into one unified collaborative care model. So it really is adaptable, and you can deliver more services than just psychosocial services through the model. Next slide. So people often ask me, like, how do you convince leadership to let you do this? Or what can you give me a sheet of paper that I can give leadership and then they'll just let us do this? And I say that building a business case really depends on the business. This game board can be used for both chess and checkers. And so in healthcare, we're all on the same game board, but we have different strategies for how to move forward and what those strategies on how to align with those strategies. And I'll give an example from my experience at Dana-Farber where I was before Memorial. So back in 2018, we were proposing to deliver supportive services to a new regional site. And we're proposing to do this through the collaborative care model of integrating psychosocial and palliative care services into one collaborative care team to deliver services at the site. And so we presented it at a meeting. I went through all the benefits of it, all the evidence, and then we had another meeting, and then another meeting after that. And at each of the meetings, I would describe it in a little bit different way, use different infographics, different analogies. And the meetings went on for about a year. And it became close to when we actually started to need to deliver services. And then I was like, this proposal is really the lowest cost proposal for us being able to deliver services. Like, if we're not going to do it in this way, like, I'll need to add some FTEs and we'll actually be able to see less patients. And that really clicked for them. And that's how we were able to move forward. And it made me realize like what was most important in their decision-making process. At Dana-Farber, support services were really viewed as a cost. And so it was the cost to value proposition for them that this was going to be lower cost and greater value. And so making it explicit like that in the very last meeting that we had really helped with the decision-making process. And so that's just saying that I think the decision-making process may be different at each of your centers or institutions. And so next slide. That's why we invited Dr. Lynch and Shelley Anderson here with us today to get a sense of how cancer center decision makers really think about collaborative care. And we have leaders on both sides of the collaborative care spectrum. So Shelley Anderson, who's the hospital president at Memorial Sloan Kettering, at Memorial Sloan Kettering, we're kind of new to collaborative care. We're launching 2 pilots later this year. And Dr. Lynch at Fred Hutch. Fred Hutch was the first center that implemented collaborative, the first cancer center implemented collaborative care, and their program's been going strong for about 15 years. So at the new end and at the very established end. And I'll start with Shelley. And in my interviews for my current position last year, I was talking about collaborative care. It was part of my job, even part of my job talk. And after I was here for about 5 or 6 months, Shelley, back in January, I came to your office with Erin Begg, who is our VP for patient services, and we pitched collaborative care to you, or pitched doing pilots of collaborative care. And I'm wondering if you could kind of walk us through your thinking process as someone who gets lots of proposals from people about new programs or new things they want to try. Like, what goes into your decision-making process, and what resonated for you in the collaborative care pitch since you greenlighted it after that meeting?
Thanks, Bill. And it's nice to be a part of this conversation today. So I was a consultant for 14 years before I got into, and then I became the COO at Brigham and Women's, and now I'm at MSK. In those 14 years of consulting, I spent a lot of time working on patient progression. And it's one of those difficulties that everyone experiences. How do you get care coordination right? So when Bill came with his proposal, the first thing that I recognized was just overall effectiveness. There were outcomes. It was clinically effective, cost effective, because we're going to be utilizing resources more effectively, and integration, really reducing the silos and making sure that there's true coordination going on. The second thing, you look at it, the quarterback of the whole situation is a social worker. And I think there's no better skill set to have around a situation of where a patient is complex. They have many different medical needs and behavioral needs going on at the same time. And the social worker looks at the whole body, the whole person. And I think they can make those connections because they're critical thinkers. They've got a deep experience in assessment and evaluation. They have knowledge of all the different resources, and they can make those connections. So actually having a quarterback is so key, because that's what really leads to that effectiveness and the better utilization, but also a much better patient experience for the patient and the family. And the equity that goes with the whole person review is something that we're always searching for to make sure there's no bias going on. And I think that social worker can achieve that. But lastly, Bill, you nailed it in the conversation that you had earlier on, is there's an ROI to this. I mean, there's a truth that we can save. There's savings that goes on when you do this the right way. So I am thrilled with this idea of the 2 pilots we're doing. One will be an inpatient, one will be in the ambulatory setting. And I'm really excited to get it going, because right now I think we have a team running around on the field, all doing the best they can. And we really do need a quarterback to make sure that someone can run the plays. And that's the way I see this evolving at MSK. So very excited. And I just have to say, I think we only had 1 meeting. So back to my old Dana-Farber Brigham days, I guess we did better than the 10 meetings that you had before the ambulatory opening. So that's why.
Great. Thank you, Shelley. So Shelley, do you think it made a difference? So I'm going to ask you questions about that meeting. Do you think it made a difference that we proposed this to you as a pilot, saying, let's do it as a pilot?
Yes.
Okay.
Yeah, I think that it's, yes, absolutely.
Yeah. So I think for other people thinking about strategies of not proposing, we're going to do this massive change, that we're going to do it as a pilot, I think is a good way to approach this with leadership. Yeah.
I think social work, there's a question in here, Bill. It says, what role are you anticipating to play? I think we're going to use a social worker as the quarterback. That's our plan.
Yeah. So in the collaborative care model, there is a role called the care manager, which I often like to call like the primary clinician instead of care manager, because it is the clinician who really is quarterbacking or coordinating the care amongst the team. So the primary clinician. So Jesse, Jesse and Tom, do you want to talk a little bit about your experience so that maybe we can have some discussion amongst all of us?
Yeah,
Yeah, sure.
let me give a perspective on a couple of issues, touching on what you and Shelley had talked about. I'd say a couple things. There's several reasons why this makes sense. The first is, and most obvious, is that it's the right thing to do for the patient, meaning it enhances patient care. You're appropriately treating patients with clinicians who are trained, skilled, and dedicated to the cause of addressing psychosocial distress and psychosocial health in the process of cancer care. Absolutely no doubt that it's the right thing to do. I think the second key reason to do it from a leadership standpoint is provider satisfaction. And I just want to emphasize how important that is. We're in a time now when, due to the political strains in our world and the cultural strains in our world, and again, one of the great things about being on both the West Coast and the East Coast and having been around the country is it's everywhere, meaning no one is happy. Young people have angst. Republicans have angst. Democrats have angst. MAGA and progressives are equally unhappy at this point, meaning we've got this time of massive distrust in institutions, incredible distrust in healthcare in a way that I've never seen in my career. And I think when we're able to provide services and care to our patients that meet their complete needs, I think it has a big impact on provider satisfaction, the satisfaction of our nurses, our nurse practitioners, our medical assistants, our physicians, and everyone else involved in the care team. So I think that's something that is sometimes underappreciated in terms of how important that element is. Third key thing of why this matters so much, if you think, Bill, about what made palliative care take off so quickly, was the demonstration that palliative care was linked to a financial outcome. And so when you linked palliative care to the fact that you could reduce your O/E mortality rates on your Vizient scores, suddenly people were interested in investing in palliative care. And so palliative care had a way of being justified in the administrative world in a way that it didn't beforehand. And I think that made a huge difference in terms of being able to generate interest and commitment in that area. With all of that said, it's still going to be hard moving forward. We're going through a time of remarkable headwinds in our industry. We're just now seeing the implication, the implementation of HR1 and what HR1 is going to do to our ability to provide extensive cancer care. We're still, even with the codes that you talked about, we're still incredibly dependent on the model of using chemotherapy revenue to support all the services we provide, whether we're talking about physician services for oncologists, psychiatrists, other medical specialties, nurses, nurse practitioners. All of those things require this model of chemotherapy and chemotherapy reimbursement at the level that the three centers you have here are able to do it at, which is very, very strongly supportive of a collaborative care model. So there's a lot of headwinds that we've got to watch for. And I think a group like this, Bill, that you're putting together, I think is really important to emphasize how critical this is to patient outcomes. So just a few of the things I'm worried about.
So if I could jump in, Tom, and thank you again for your insights and advice. I think that a lot of the audience and the folks who really want to pilot collaborative care and ultimately roll it out, are still struggling with kind of how to best present it and sell it to leadership. I think most leaders will agree that supportive care is important, but I think like you said, the headwinds are so strong that it's hard to kind of get the resources that are necessary. And just wondering if you have any kind of really concrete advice in terms of, like what kind of data that, they could present, or what kind of approach they could take to leadership to try to get that buy-in.
So, I mean, Jesse, I think some of the things I just touched on, I think are still important. I think in our institution, we know, and maybe this is true at Dana-Farber. Actually, I know it's true at Dana-Farber. It may not be true at Memorial. We have no beds. We're out of beds. We have no hospital beds, despite living in an outpatient world. Okay. Oncology care is outpatient care now. We know that. But when you take care of enough patients, you still need some inpatient beds to support those patients in their care journey. And as Jesse knows, we're out of beds at UW and the Hutch. We don't have any more beds. So I think, Jesse, one way that's been very effective, and I know you haven't come to me yet with what the side of this budget's going to be, but I think one thing that's been very effective is showing impact on length of stay and appropriateness of care, and what this does to Medicare star ratings and et cetera, et cetera. So I do think there's a business case to be made for collaborative care in terms of how it, not only for being the right thing to do, but for also being something which is in the interest of the institution economically. Shelley, I don't know what your
Yeah, I was gonna say from 109% occupancy organization to another 109%
okay, all right.
occupancy organization, we feel the same pain. I also think it's simple things like, so like Bill said, I think the pilot really works with folks like me and maybe like Tom to say, let me prove to you what the outcomes are going to be. But Bill's going to measure things like consult volume alone. We talk about utilization. I mean, we've got Epic. We can measure consult volumes because right now you've got a whole different, a potpourri of consults going around versus having, again, one quarterback taking a look at the situation and making sure that we're most effective in the choice of what that patient needs at that moment in time. So I think there's a lot of other measures that don't necessarily always have to relate to, as Tom said, on like the stay reduction, but a dollar value, but it also just shows the efficiency that we can create. And I love the idea, Tom, of just the whole care team experience, right? Like people don't want to be doing things that is not worth their time. And I think this whole approach can help do that. And Bill presented to me something very simple. I mean, I would suggest keep it as simple as possible because it just makes, Tom, you said this, it just makes sense.
Yeah, and I think at the time, the other thing is in this time of social isolation and disconnection, which is really what I think we're experiencing as a society. I think that ways that we can work toward creating an environment where our caregivers feel supported and that their institutions are doing the right thing, I think becomes important as well. And I don't know, it's part of it's generational. We've got a multi-generational workforce with the four main generations really seeing things slightly differently in terms of how they look at their jobs and how they look at their experience in the workforce. But I think all of them still share this concept of wanting to be more connected to each other and to their patients. And I think that a collaborative approach, and I think one of the things about psycho-oncology that, at least in my career when I was practicing actively and worked with Bill and others at MGH, was I think that psycho-oncology provides as much benefit to the caregiver as it does actually to the patient. And I don't think you can underestimate the importance of that. And there are productivity gains that I think you can tie to that if you look carefully enough.
Yeah, and I'll just add and reiterate, when we started this at Fred Hutch back in 2010, Tom, this was before your arrival, and if you were here earlier, we probably could have gotten it started a lot earlier. But when we started in 2010, we started with a pilot as well. We started in 3 clinics and piloted it for 6 months and presented the results, and that really included, very concrete outcomes data as well as patient and provider satisfaction data. And we presented at our medical executive committee, and all the other clinics who did not participate in the pilot said this is what they want, and so that's how we were able to roll it out, and I think that worked really well, and sounds like that worked well at Dana-Farber and is going well at Memorial as well.
I'm going to ask, since I was saying that collaborative care has a marketing issue, Tom and Shelley, how would you describe it? Like if you were talking to someone at another leader at another cancer center, like saying what it is, like how would you describe it in a really simple, succinct way that another cancer center leader would get?
I feel like I should let Tom answer first because he's been experiencing it longer. So my assessment, I really do think it's putting a quarterback into the psychosocial coordination of patients and families in active treatment, right? I mean, I think that is really it's really just much more effective and efficient for everyone, and hopefully higher satisfaction.
Yeah. I think similarly to what Shelley said, comprehensive, coordinated care that addresses all aspects of the patient's psychosocial experience. And by definition, it's multi-specialty, not just multidisciplinary, but multi-specialty. So I think that's probably the simplest way from the way I think about it.
Yeah.
One of the things that I think people struggle with is, that psychosocial care does not, I mean, there are billing codes, but it does not bring in a lot of revenue, and we do know that there is a cost offset there that, it can decrease unnecessary clinic visits. It can decrease unnecessary emergency department visits, shorten length of stay, even decrease unnecessary, medication use, in terms of pain medications, things like that. Are those compelling arguments, do you think, Tom and Shelley, for folks to make? Because everybody's concerned about the financial aspects of healthcare these days.
I mean, I think just
there's a cost there's a cost side, right? And then there's like a payment revenue side, right? And I think I think you can look at both, right? Yeah, for sure we want to make sure that we're capturing payment for services rendered. That's fine. And if I mean, like you said, Jesse, the numbers may not be that great, but we're going to capture that. I look at more on like, are we being efficient on the cost, the affordability side, the value side? And I think this is the type of model that can really help drive that. You talked a lot about several different things that relate to utilization. And I think those cost aspects are really important, not only to us as providers, but also to our communities and patients and insurers.
And Jesse, this may sound crazy, but I don't think you're ever going to make it pencil out if you're trying to say that. Okay, it's never going to pencil out. Never going to work. It's never going to work as easily. If you came to Shelley and I with a plan for building an ambulatory chemotherapy infusion suite in Staten Island, it would take Shelley about 20 seconds to decide that was the right thing to do. Okay, because it's clear what it's going to do, how many patients it's going to treat, what the margin is going to be, and how to pay for it. When you and Bill and others come to us with supportive oncology requests, fundamentally, at the end of the day, it's going to be our commitment to doing the right thing in the setting of our patients. And yes, you can offset some of the costs with, I mean, I think one of the areas that we're looking at UW and the Hutch specifically is our mortality. I mean, we're getting hammered on Vizient mortality ratings, even though fewer people die per patient at the Hutch compared to either Dana-Farber or Memorial. Yet our observed to expected is not good. And so we want to look at ways of making sure that our care is appropriately delivered in the right place. And the same thing with psychosocial distress. And then coordination of care and parenting. We haven't even talked about parenting and the importance of some of the Paula Rausch work that Bill is so well familiar with. So I think that using the arguments on length of stay, on survival rates, Vizient ratings, employee satisfaction scores on our employee satisfaction surveys, all of those things are great. But at the end of the day, you've got to get leaders who actually buy into the principle of doing the right thing, because it's never going to pencil out. I don't mean to be discouraging. It's just never going to pencil out.
I agree.
Yeah. So I'm going to raise a little counterpoint to that there are several different companies now who have business models of doing virtual collaborative care for oncology
So color,
centers. I'm sorry.
color.
There's maybe 5 different
Okay.
companies.
Color was one that I've heard of.
Okay. And so these companies have been able to find ways to make it profitable for them. They're not in cancer centers where cancer centers need to take care of all of the patients. And so I think being in a cancer center where you need to take care of all the patients, it may not pencil out, like you were saying, to be a profitable thing, but it can help offset some of the cost. Yeah. Yeah.
Thank you. I think that we should probably wrap up this section, but I want to ask Shelley and Tom if they have any kind of final words of advice. We have a large audience today, we are so lucky to have both of you here. So, any final words of advice for folks, out there who are really interested in this model or are considering this model and want to try to sell it to their leadership.
I mean, I'm just going to repeat this again. It makes sense. It's like cancer care delivery is so complicated, and it's not just about the patient, it's about the entire family, the caregivers, right? It's so complicated. You really need a point to help make sure that we're moving patients in the right direction. And so I would say go for the pilot. I can't imagine there's not a cancer center leader out there that wouldn't want to do a pilot in some way, shape, or form, because you can always say no at the end. And so keep trying, I would say, until you get your pilot.
But we don't want you to say no at the end, Shelley.
Well,
No,
because
it's on record, Bill.
yeah, but I think Shelley's right about that, because the pilot's going to show you, particularly depending upon what you measure, it's going to show you a broad impact, and that's what you really want to hope to demonstrate. And I think that's what Jesse, what you and Bill have done so well throughout your careers is doing that, and demonstrating broad impact on patient outcomes and patient care.
Actually, one final really quick question, because it is now being included in clinical practice guidelines, like NCCN practice guidelines for distress management. How compelling is that for administrators and leaders in terms of being now officially part of standard of care clinical practice guidelines? Is that helpful?
It doesn't hurt.
Doesn't hurt.
I mean, guideline concordant care is something we love to talk to insurance companies about, and love to tell the Blue Cross Blue Shield of our various states that we're practicing guideline concordant care. One other point just that I've been thinking about for the last 2 seconds is don't worry that it doesn't pencil out. Okay, meaning if you press Shelley or I, there's very few things we do that actually do pencil out. We constantly support things in medicine that we lose money on. And every hospital does, and every cancer center does. So you shouldn't feel defensive about the fact that the care, that a collaborative care model is not making the same margin that pemetrexed or nivolumab or pembro make. Okay, that's okay. There's tons of things we do that in medicine that don't have a margin associated with them, but we do them. So I would say to the people on the webinar, don't let your administrators tell you because there's not an ROI or a direct profit or margin to this service, we're not going to do it. Because if they use that criteria to justify what's done in medicine, medicine would become joint replacements and chemotherapy administration. And after that, it gets really hard to find, yes, neurointervention, neuroradiology intervention, those 3, okay? There's just not a lot of, there's a lot of things we do because they're the right thing to do. And all the pilots and this effort and the effort that you're talking about today, what they'll do is help make it a little bit easier for the administrator to feel more comfortable about that. And so things that demonstrate outcome and better impact, I think, are always going to help you.
And I'm so proud of Tom and myself that we got through an entire talk without using AI in anything, Tom. How about that?
We did. That's great.
Right? Next time.
Yes. Well, we actually have
No,
an
no, I can't say it. Can't say
No, but we have an AI collaboration between Dana-Farber Memorial, the
I know.
Hub, and Johns Hopkins.
Hey, but the last thing, Bill, Jesse, and others, it really is the trust that you build as a leadership team to take on pilots, to take on new innovations, and I think that's really what it's all about. So,
Thank you so much, both of you. I don't think we have. I think some of the questions in the chat are really good questions that Bill and I will try to address in the next webinar, actually, which will focus on conducting a pilot. So,
and we also have another office hours coming up where we can address some of these too. Yeah.
Right. So again, Shelley and Tom, thank you so much for joining and offering your valuable insights and advice. I know that everybody on this webinar have benefited greatly from this. So thank you again, and you're welcome to stay. Would love for you to stay if you can, but we know you're very busy. So thank you again.
Thanks, guys.
thank you.
All right. So I'm going to just present very quickly a few slides that kind of set the context and for conducting caseload reviews. And then we're lucky enough to have a team from Dana-Farber to actually demonstrate some mock case reviews shortly after my few slides here. So next slide, please. So just to reiterate, and some of this we presented briefly in the past as well, but psychiatric caseload reviews are not what they're not detailed case conferences. They're more akin to what I would say clinical rounds, where we're able to get through 6 to 12 patients per hour. And really provide a very focused discussion of patients who are prioritized as kind of highest need patients, like people with safety concerns, people new patients who are highly distressed, patients who are being followed who remain distressed, and it's really a very focused and very efficient way to discuss cases and really with a focus of discussing treatment plans and treatment adjustments that might be indicated to get patients feeling better. And next slide. The general structure. One back, please. The general structure of case presentation and case review is very collaborative. It's a way to for the whole team, a social worker, psychiatrist, and typically a psychologist as well. We have all three disciplines and many trainees in these case reviews, and we are able to very succinctly discuss cases and focus on what are the key treatment adjustments that might be indicated. And it's a great time to really provide some education kind of in multiple directions on specific clinical aspects of each case. And it's a great learning opportunity. And it's also a way for the team to really come together and provide support for each other. With a collaborative care model, there's no sense that you're kind of out there on your own, dangling by yourself. Next slide. And an important component, as we've mentioned before, of collaborative care is the patient registry. So every social worker has a registry. It can be a simple, Excel registry like the one shown here. or it can be integrated into Epic. And it's a way to really, track clinical outcomes and follow-ups. It's a way to document what your treatment plan is and what your follow-up plan is. And it's a way to really flag the patients who need to get the most attention, and flag, people with safety risk and so forth. So it's really a critical aspect of the caseload review. So I'm going to stop there and really turn it over to the Dana-Farber group to demonstrate, I think, a couple of cases for you. Take it away.
It might be good, Dana-Farber group, to first introduce yourself and your discipline so people kind of know what role you're playing in the mock case review.
Yeah. Thanks everyone for being here. I'm Joelle and I'm a social worker at Dana-Farber.
I'm Tim Steinhoff and I'm a psychiatrist at Dana-Farber.
And I'm Caroline Cubison. I'm a palliative care doctor at Dana-Farber.
And with that, I'm going to jump into cases. So my first patient that I'm presenting today is a new consult to me and also new to the collaborative. Irene is a 48-year-old married Caucasian woman who lives with her husband and her 2 young children. She has a diagnosis of left breast DCIS, and she has undergone a mastectomy and began taking tamoxifen about 3 months ago. She was referred to social work more recently due to increased anxiety and panic since her new breast cancer diagnosis. She has shared with me that over the past few months, she has had several emergency department visits where she's believed that she was having a stroke or a heart attack due to physical symptoms, and ultimately was medically reassured, and this was thought to be anxiety. So today, in terms of my consult for the group, I'm hoping to talk more both about the potential for a referral to psychiatry, for a medication recommendation, specific to this patient currently taking tamoxifen, as well as would be appreciative of any further thoughts around, best psychotherapy support for this patient. A little more relevant history for the group is that her GAD-7 score was a 15, so indicating pretty severe anxiety. The PHQ-9 was a 7. She does report history of lifelong anxiety that predates cancer, but has been significantly exacerbated after this diagnosis. She had been working with a therapist for a few months before being diagnosed. She reports she did not find it helpful and had stopped seeing her recently. She is prescribed by her primary care doctor Ativan 0.5 milligrams PRN for panic attacks. Does find it very effective, but tries to take it sparingly. Her primary care doctor, also predating cancer, has trialed several different medications for her anxiety. She has not stayed on any of them for very long, has kind of reported side effects with each medication. Had taken Lexapro 10 milligrams for about a month. She stopped due to headaches and nausea. Had been on Effexor 37.5 milligrams, stopped after 2 days due to increased anxiety and jitteriness. Had also been on Buspirone 7.5 milligrams for several months, but stopped due to increased drowsiness. So she really has just not found a medication that she was able to tolerate to this point. No history of suicidal ideation, no history of self-harm, psychiatric hospitalizations, and no substance abuse, current or history of. She does describe health anxiety that predates cancer and certainly is elevated now. A little more details around the hospital trips. Over the past few months, she has made 4 trips to the hospital, one of them by ambulance from her job as a dental hygienist, and kind of describes each time that she was experiencing internal shakiness, dizziness, muscle tension, and flushing that she really worried were medical events. She is able to verbalize that now, even driving into work, she begins to have anxiety and sometimes panic around if she will have a panic attack again when she gets to work. A few more details. She does describe kind of sandwich generation related stressors. She's one of three, the only sibling caring for her elderly mom, and also taking care of her two kids. So in terms of my assessment of this patient, certainly I would say generalized anxiety disorder with panic, interventions that I have utilized after meeting with her a few times has been mindfulness and relaxation training, CBT. Now hoping to explore psychopharm. This patient is asking for help with this to kind of help control for some of these physical symptoms of anxiety. And she is involved with our integrative medicine team at Dana-Farber, is following up with them. And I will, for now, see her biweekly with the hope of at some point transitioning her back to community care.
Thanks, Joelle. And is the patient interested in a psychopharm consultation with psychiatry?
Yes, she's very open to that.
Okay. I think that makes sense, given the fact that she's had multiple medication trials that have not been successful. It would be helpful to sit down with her and get a better understanding of what may have been some of the adverse effects or lack of effects she's felt with previous meds, and come up with a plan to try and help her from a pharmacologic standpoint.
Thank you.
I would also say it sounds like this anxiety predated her cancer diagnosis, but I wonder, Tim and Joelle, if in your time working with her, it feels like there are sort of concerns about her mortality or existential distress that you think we could be helpful, even just doing a one-time palliative check-in so that she knows what kind of support would be available in the future. Let me know and we can think about that too.
Yeah, thank you. That's really helpful. There are certainly, I mean, her mind, when you kind of talk through what the anxiety looks like, is going to mortality. And what if this comes back? My kids are so young. What will that look? So that is certainly a big source of the distress.
It may also be helpful to set her up with a parenting consultation with Dr. Muriel to think about sort of ways of speaking to her kids in age-appropriate, developmentally appropriate ways. May also alleviate some of her worries.
Yeah, I think that's a really good that they're both elementary school age, so she has communicated with them, but I do think that is a big piece of kind of her distress since the diagnosis. Okay. Thank you both. I will work, Tim, on reaching out to get her set up with you. I think she'll really appreciate that. I also wanted to update the group on a patient who, Tim, you had made a medication recommendation for in the past, so I appreciate that. He is not new to the collaborative, but is now agreeing to a palliative care referral, which the team is very happy about. So just briefly to kind of go over him again, this is a 60-year-old Caucasian married man. He lives with his wife and their three children. Was originally diagnosed with prostate cancer in 2018. He has undergone multiple treatments at this point, with some periods of disease stability. More recently, his cancer has progressed pretty significantly through his treatment. He is now starting on an oral medication and palliation, and is coming to clinic for supportive care. I have been following him for coping support related to anxiety, low mood, and insomnia, and more recently, goals of care conversations. Their care team has also been concerned regarding his hesitance to engage in conversations around his prognosis, which unfortunately is poor. In a past collaborative consult, Tim, you had recommended starting Prozac. He is now titrated up to 20 milligrams. So specifically today, I'm hoping to talk about referring him to palliative care. Caroline, he is now open to it because his cancer has metastasized to his bones, and he's having a lot of pain. So he is open to speaking with you now about that. He also had kind of brought up the medication and if it would be appropriate to increase it or change it at this time because he's having a harder time coping. And also, I'm open to any kind of feedback from the group about providing therapeutic support to him around his prognosis, as well as talking to his teenagers. He has not shared this cancer diagnosis with them. He has really been declining to do that. Just more kind of interim history on him. His PHQ-9 and GAD-7 scores have been historically low. Recently, they have increased pretty significantly for him. The GAD is 12 and the PHQ is 14. He's historically reported that CBT and mindfulness techniques have been helpful with his sleep and managing his anxiety. He reports that he has been better able to engage in activities that are meaningful to him, that he had stopped doing, such as reconnecting with his church community and friends that he had been kind of isolating from in the setting of his cancer diagnosis. He, as I said, had started the Prozac after a past SOC presentation. He did feel that it helped his mood and anxiety. He is less sure of the benefit recently. And he is saying that he's struggling with anxious thoughts at night that are causing insomnia, an issue that the medication had initially really helped him with, and no drug or alcohol use. So just kind of an assessment, his prostate cancer has continued to progress through treatment. Options are limited at this point. He is having significant pain due to bone metastases, and there's concern for risk of cord compression due to the spinal metastases. He has historically reported he copes best by compartmentalizing his cancer diagnosis, and he has been resistant to prognostic conversations for that reason. Recently, due to his level of pain, he is reporting he's unable to distract from his anxiety related to cancer. And he has been less able to engage in physical activities that he enjoys and finds meaning in. He lives with his wife. They're 3 teenagers. They homeschool them. He has shared that his children know that he is getting treatment, but he has not used the word cancer with his children or extended family, and expresses this is due to wanting them to maintain their sense of normalcy and not to cause them to worry. He's able to engage in some conversations around legacy planning and in values work, but really cannot tolerate more in-depth conversations about his goals of care and his end-of-life wishes. He does report that his faith is important to him and a comfort to him, and more recently, he's started going to church again. So just kind of proposed planned interventions. I will continue to work with him around coping with terminal cancer. He is asking about his medication, if there's a benefit in increasing it versus continued talk therapy combined with now accepting palliative care support. And then again, we're looking to refer to palliative care. And I did talk to him about spiritual care as well at Dana-Farber.
Yeah, thanks, Joelle. I have a couple of thoughts. I mean, clearly, I think this is a completely appropriate patient for us to see, and I'll do my best to expedite his consult with our team. And I hear that there's been a real hesitancy to talk about prognosis in the past. Do we know if he has a healthcare proxy? Is it his wife?
Yes, it is his wife.
And
yeah.
Do you have a sense of how communication has been with her? Sometimes patients prefer sort of someone else in their family to have those conversations first and then share information with them later. Have you been able to gauge that at all?
Yeah, that's a really good question. It is tough. She does not come to clinic with him. He prefers to come by himself. He attends the office visits by himself. I know she had come a few times at the beginning when he received this diagnosis, but she has not been back since. And he is saying it's because she's homeschooling the boys, so she's home with the kids.
I see. Okay. I also hear that he's really uncomfortable right now, and it sounds like pain is uncontrolled, which, in my experience can also drive up anxiety and distress in general. So I feel like a first step is to really try to dial in his pain management so that he's more comfortable and maybe could tolerate these conversations a little bit more. And I also wonder if just getting better symptom management would also help his mood and his other psychiatric symptoms too. But Tim, what are your thoughts about adjusting the medications from a mood perspective right now?
I think it would be reasonable to titrate the Prozac further, understanding that there is pain that is sort of complicating the picture. It sounds like he felt there was benefit when initially starting the medication, and that effect has sort of plateaued. And Joelle, you're describing some symptoms that are not directly correlated with sort of how the pain is experienced across the day. And so I think it's reasonable. So I can recommend to the oncologist that the Prozac be increased further, and then we can monitor the effect in combination with meeting with Caroline and hopefully dialing in some of the pain symptoms. Something else that I was wondering, Joelle, is you mentioned at the beginning that the team feels a sense of relief that he's open to meeting with palliative care now. You've been working with him for some time. Are there things that you have sort of learned along the way about working with him that would be helpful in sort of continuing the conversation and transitioning into some of these other symptom related and mortality related questions or conversations?
Yeah, that's a really good question. I think just really aligning with him and getting to know him and what's important to him. He did really well in terms of his faith is extremely important to him. It's a comfort to him. And I do think the continued attempts by the oncologist, very well intentioned, to talk about his prognosis was kind of causing him to shut down. So with the time that you have kind of slow and steady, he does better with.
Yeah, it sounds like asking for permission, and gauging like how much he wants to be involved in the conversations versus someone else would be a good thing for us to explore around his communication preferences.
For sure. Yeah. Thank you both.
Well, thank you so much for illustrating what a typical case review session would be, a mock team review. I think this was very nice, illustrated both psychosocial needs and palliative care needs being addressed together in a team. And I think it gives people a sense of what these meetings are and how you can have some pretty in-depth discussions about patients in a short amount of time. And these really are work-related meetings. So thank you so much for doing that. We're almost at the end. I know there's been lots of questions in the chat today. We are going to be having one last webinar with presentations that's going to be talking about launching a pilot, looking at outcomes, which is some of the questions that came up. Some of the questions also could be answered from some of the previous webinars about how to think about the different components or roles involved in a collaborative care team. And then we'll also have a office hours, which will be just open questions for people who've been part of the webinar speaker series over the time. Jesse or Teresa, any other closing comments?
Yeah, I just want to say thanks for the mock case reviews. Very impressive kind of summary, and as you can see, Joelle came very prepared with very succinct kind of questions that she would like help with, and it was a really nice kind of illustration of a really focused discussion. Obviously, you can only do so much in a very short mock, presentation like this, and you guys did a nice job. We'll be happy to answer any other questions about, case presentations, etc. We didn't. Maybe you can back up to, just a couple of the slides that one. So we have some slides here that we didn't get to. Go back one more. That kind of summarizes and the structure of the case presentations and the discussions, and we can happy to talk more about that in our office hours. So thank you everybody for joining, and I hope it was a useful and informative session. So thanks to all our guests as well. Really appreciate it.
Thank you. And on behalf of the Association of Cancer Care Centers, we'd like to say thank you to all of our guest speakers and faculty and content experts. We always love to showcase people doing the actual examples, and I think this was wildly helpful. So thank you again to the entire Dana-Farber team for coming and providing us with a case example. Just a reminder again that in the chat, there is registration links for our upcoming webinars and our office hours. We are also posting all of our series on our website, and we hope that you will take a look at that as well. So with that, thank you so much for attending our webinar this afternoon. Thank you.